Welcome to part 3 of Seminar 1 of What is Addiction. This part looks at risk factors for addiction in relation to preventing addiction and treating addiction. Firstly, how does substance use begin? And in talking to people with substance use issues, common stories emerge which give us a clue to trigger factors or precipitating factors and predisposing factors. So just experimental and risk-taking behaviour, which is a teenage phenomenon, is one factor. Its availability. So, for example, if alcohol is very easy to procure, then there's a greater chance that alcohol use and possible dependence may develop. If all your friends are doing it, if there's an element of social pressure to do substances, then that increases the chances of starting using. If the culture of origin in your family was that alcohol was a very normal thing to partake of, but in large amounts, then it's a greater chance that you will also follow suit. Exposure to harder drugs through contact with people using less or softer drugs, less hard drugs, this is called the gateway effect, and it certainly may be a reason why people progress up to harder drugs. Inadvertent exposure through medical causes is one cause of opiate addiction. Certainly escape from emotional pain is one of the reasons why people might discover the effects of opiates or other substances. And sometimes just hopelessness or loneliness can lead to substance use. And certainly not forgetting the pleasurable aspect of substance use. Certainly it is fun in the early stages, and these are all common stories in the onset of substance use. So whilst many people try substances at some point, the majority of people who do so do not become addicted. That is, they don't have problematic substance use. These three photos shows the young Barack Obama at college trying a cannabis cigarette, and as far as we know, he didn't develop major substance use problems in his life. If so, he certainly managed to have a very successful career at the same time. However, to understand who is at risk of becoming addicted, we need to look at our models of understanding, and this we'll do in the next few slides. If we take a step back and away from the biological and psychological processes that we've been looking at, and look at population studies, we do find that there are associated factors with addiction which can help to inform us as to who might be at risk. Please note that these risk factors are not direct causes, and no inference should be drawn about one's own situation in looking at this. Childhood mental health issues are a major factor. The commonest would be ADHD and trauma caused by neglect or abuse. Secondly, parenting deficiencies, which may be due to mental health issues, substance use, domestic violence, or neglect through social poverty, etc. Adult mental health issues are also a major cause. For example, in bipolar disorder, substance use is used to help individuals use it to help manage their own mood. The availability of substances is a well-recognised phenomenon, and therefore governments take effort to control availability of alcohol and tobacco using pricing, visibility and advertising, and limiting places to smoke or to consume alcohol. Peer group is a factor, but also a protective factor, even when peers are using substances. It's often the less integrated individuals within a group who tend to get into addiction problems in a big way. Heredity contributes to about 50% of the risk of an individual for developing substance use, and it is a large factor that should be taken into account by people whose parents have had heavy drinking histories. Risk factors are also offset by protective factors, and these are in a dynamic balance like a tug of war. These factors are useful to know as the balance can be modified, for example, early intervention programs. Let's look now at protective factors by hearing about the so-called rat park experiment. Professor B.F. Skinner was a behavioural scientist from the 40s through to the 60s who studied conditioning, that is, patterns of behaviour automatically learnt due to pleasant or unpleasant consequences. He developed an experimental technique, a box for animals which had levers and mechanisms for dispensing food and water, which also delivered a chosen stimulus, either pleasant or unpleasant, such as a substance or an electric shock. Just like Pavlov with his dog experiments, Skinner was studying conditioned learning, but his technique enabled more sophisticated experiments, such as how attractive a stimulus was and how long learned behaviour persisted after the pleasant stimulus was removed. Rats placed in these boxes with a morphine drip as stimulus could become addicted, that is, if we can use that term, to the same substances that humans become addicted to, due to their rewarding effects for rats. Once rats had learned to use the morphine, use would increase and continue until death from overdose or from neglect of water or food intake occurred. The experiment supported the idea that drugs were irresistibly addictive and therefore should be eliminated from society at all costs. This supported the war on drugs approach, where most money and effort was directed towards policing illegal drug importation, distribution and sale. Some would say to the neglect of other approaches. Canadian psychologist Bruce Alexander questioned the idea that availability of drugs was the main factor in addiction, observing that Skinner's box was not a natural environment for rats, and questioned whether the rats would be as vulnerable in a healthy environment. In his experiments, rats were tested in an environment where the option of morphine was still available, but compared outcomes between two environments, one where everything was available that a rat might need, comfort, toys, male and female rats, and another environment, the solitary basic cage environment. He and subsequent researchers found, in essence, that the richer environment had a significant protective effect on the rats against substance use and dependence. Rats have social, sexual, play, and environmental needs which appear to compete with substances and are preferable in circumstances where those needs can be met. Such protective factors need to be part of our understanding of how addiction develops. So in order to prevent and treat addiction, we need a model of understanding. A model being a representation of a real phenomenon using diagrams, descriptions, mathematical or physical representations. They used to make things easier to understand. For example, working with a model aeroplane teaches much about flying and life-size aeroplanes. In responding to addiction, society, governments, helping agencies, political groups, and faith communities follow a model of addiction, either consciously or unconsciously. And these models are based on their underlying beliefs. These models lead to ways of responding to the addiction problem. Without a good model of addiction, responses may be unbalanced, ineffective, unethical, or even harmful. For example, a political group campaigning on the issue of high crime rates and hoping to exploit community mood of outrage might use a model which heavily focuses on the moral failure model and propose harsh sentences and zero tolerance of drug use. In developing a model of addiction, let's recap on some of the learnings so far. We've looked at the biological factors or the brain factors, the way the brain learns and adapts automatically, the role of dopamine in pleasure and learning, the balance between the smart brain and the animal brain in terms of impulse control, the effect of substance use on the dopamine system, and the secondary damage to the brain caused by substance use. These are all biological factors that we could attribute to the disease model of substance use disorder. We've also looked at automatic psychological mechanisms which lead to repetition of behaviours and forming logical conclusions or beliefs through reinforcing consequences. The activating events may be external places, people, situations, or internal factors such as depression, pain, or loneliness. Social influences are a major source of activating events, learning opportunities, and reinforcing consequences. So we talk about psychosocial factors. The brain also has a long developmental process in humans, which progressively sophisticated patterns of relating, thinking, and behaviour develop, through which the personality forms. Whilst on the subject of personality development, you've probably heard of Sigmund Freud and his theories of personality development, the oral phase, the anal phase, etc. Apart from psychoanalysts, most people don't think in these terms, but there is the underlying idea that there are critical phases in psychological development which can be delayed or interfered with through adversity or neglect. A possibly more intuitive model is by Erik Erikson, as shown here, proposing that at various stages, certain developmental tasks are at stake, which can result in more or less successful outcomes, with formative effects on the personality. Whilst such a model is a simplification, it may explain why childhood experiences can be so critical for adult mental well-being, and possibly contribute to the development of addiction when things don't go well. So, if rats are afforded significant protection from morphine dependence by having their naturally occurring needs met, let's look at human needs. Although we share some similarities with rats at the level of basic needs, humans have highly developed frontal lobes and very prolonged periods of development to maturity. So we may assume that our needs as humans are unique. How do we understand these needs? Maslow in 1940 published a model to describe human personality development, and whilst only a theoretical model itself, it has served the test of time as a basic framework to think about human needs. The pyramid concept conveys the idea that during development, the higher level needs can only be considered if the lower level needs are met. Later, as maturity has developed, the higher level needs can be more important than the lower level needs. For example, in war, one's safety and physical needs can be overridden by higher considerations. The distress of unmet needs can also be lessened by the use of substances, which works in different ways. For example, removing emotional pain, initiating one into a community of users, and in some cases, esteem and accomplishment can be met by successful operation in that community. Later in his career, Maslow introduced another level, that of self-transcendence, or one could say spiritual needs. This has been explained as seeking to further a cause beyond the self and to experience a communion beyond the self. Another way of saying this, spiritual needs may be explained as matters to do with meaning and purpose, conscience and forgiveness, connectedness and love, faith and hope, evil and justice, death and loss. So now, having considered topics relevant to addiction, let's return to the model of addiction. A model needs to work under all circumstances to be fully useful. Some partial models have been put forward and used over the years, such as the learning model. We unconsciously learn to return to a substance if exposed to it through conditioning. The disease model. The physical brain changes make it difficult to stop being attracted to the substance and affect our ability to function without it. The social model. We are relational creatures and strongly influenced by peers, culture, and social disadvantages such as poverty. Environmental model. Availability correlates with likelihood of exposure, therefore likelihood of addiction. The developmental model. Trauma or neglect leads to personality needs which are partially or in the short term met by substances. The self-medication model. Pain, both physical and emotional, can be avoided with substances. The moral failure model. Two people given similar backgrounds may make different choices, some bad and some good, when faced with moral dilemmas. Choice or lifestyle. Simple choice for various reasons, be they philosophical outlook or placing a high value on some kinds of pleasures. These models alone do not fly under all circumstances. The complexity of addiction is best explained by a complex model. That model, which has great acceptance, is called the biopsychosocial model of addiction. And depending on your understanding, one could also add spiritual. This model means simply that one has to think broadly when approaching addiction and not be limited to one approach or one at a time approach. Often a multi-angle approach is required. For example, the model aeroplane requires all things working simultaneously: the shape, weight, engines, fuel, control, and controller for it to fly. How might we apply this model? A biological understanding of addiction leads us to try to reduce exposure of the substance that causes brain changes. Therefore, the approach here is about minimizing exposure, that is on the supply side of the equation, reducing the need for the substance, which brings on brain changes, that is on the demand side of the equation, and then reducing the physical harm that is caused by the substance, which is called harm minimization or harm reduction. Under the supply side, there are such things as substitution of safer substances, for example, methadone and buprenorphine in the case of illicit opiates like heroin. Then limiting exposure to the substance through laws around availability, pricing, and legality. Preventing substances getting onto the market through policing and interdiction of illicit substances at borders. In the case of pharmaceutical addictive substances, for example, OxyContin, the regulation and monitoring of those substances. Under the demand side, we have treatments to reduce the need for the substance, for example, medically supervised withdrawal services and relapse prevention medications. We can treat predisposing mental health conditions with biological treatments. Those conditions include ADHD in children and bipolar disorder in adults, and we have medications that are quite effective for those conditions. We know that improving population's general health and nutrition from the womb through to adulthood contributes to resilience against substance use. And under harm reduction, we have the management of complications such as infections, liver, lung and heart disease, psychosis, and we use biological treatments for these things. Teaching safer techniques of using, providing clean equipment, and having safer places to use, which often link people to services that may provide treatment, is also a way of reducing harms. Using the user network itself and information sharing between people who are using often prevents harm from emerging dangers such as bad batches of party drugs. We'll go on to look at the psychological approaches in the next slide. A psychological understanding of addiction, which does overlap with social approaches, directs our attention to preventative and treatment approaches by looking at brain programming, or if you like, the software of the brain. On the prevention side, one thinks of overall psychological development and the benefits of well and stable parents. Sometimes there is a need for child protection of children at risk of neglect and trauma. Early intervention in children with mental health issues is important. Enhancing the resilience and life skills of adolescents through well-designed school programs. The provision of accurate and relevant information to people who may be at risk of using substances. And the reducing the attraction of legal addictive substances and gambling through limiting advertising and promotion. These are all preventative psychological activities. On the treatment side, we have treatments targeted at substance use, which work on automatic beliefs and behaviours that have come to drive substance use. Working on the ABC pattern of automatic reactions that we've seen earlier. Also helping people work through motivations for and against substance use. These approaches are often called talking treatments, but also include reward-based treatments and programmed activities. And this is closely related to another category called recovery activities, which involves various settings, both community and residential, covering life skills training, programs to develop routine, gradually increasing responsibilities, reconditioning for work, and a lot of recovery talking groups, often in the presence of a therapeutic community. Psychotherapy or deeper long-term counselling is important for many people with underlying issues. And psychological therapy for complications such as secondary trauma, depression, anxiety, and psychosis are all psychological treatment options. Social approaches to addiction include, at the individual or family level, managing social contacts, that is, consciously deleting phone numbers and avoiding running into people who might trigger drug use. training for family and friends, that is to better help them to work with their loved ones in addiction. Mutual help groups, for example, AA, NA, SMART, or user groups who share information about dangers. Therapeutic communities, which are really recovery communities. These can be residential or community-based. Early intervention for at-risk young people. At the community level, addressing stigma and wrong understanding about substance use. Forming local groups to reach out, advocate for and assist young people with substance use. Opportunities for young people in recreation, training and work. School programs which involves resistance training, resisting drug taking, normative education, that is challenging what's perceived as normal amongst young people, and providing quality information. At the political level, fair and adequate funding for treatment services for substance use, diverting funding from punitive to recovery approaches, that's decriminalising substance use. That's not to decriminalise substance sales and at the high level, but at the user level, decriminalising the process. And addressing root causes such as social disadvantage in health, education, housing, or amongst minority groups. The above 3 slides just give examples. It's not an exhaustive list, but the kind of approaches that can be used using the biopsychosocial model. That's the end of this talk, and the next 3 talks include one on amphetamines, how to help your loved one who is suffering substance use problems, and a talk on specific substances, alcohol, cannabis, and opioids. I'll leave you with a slide following this, which is shows a list of risk factors and protective factors, which might be worth studying, and it summarises a lot of the issues that we were talking about in the last few slides.